So today I'm going to talk about toxicology. It's a really huge subject, so I try to focus on some points there. So the objective of this presentation, we're going to talk about clinical approach, general treatment strategy, and the common poisoning in ICU. So just a few facts in epidemiology. So the poison control in the United States reported over 2 million of human exposure calls in 2018. That time overall mortality was under 0.07%. 31% of cases required management at healthcare facility, 8.4% require hospital admission. 2017, more than 70,000 Americans died of drug overdose, and 68% was opioid overdose. So initial evaluation and toxicology is going to be basically similar to the initial evaluation. So we start with A, B, C, D, and E, and then the antidotes. So first you have to see the airway, make sure the airway is clean, no trauma, level of consciousness. If there is secretion, you have to clean the secretions. If there is any foreign body, you have to remove. And then see the breathing. Is a patient is apneic, hypoapneic? Does he needs oxygen supplementation, non-invasive, or patient require intubation? Then you look for blood pressure, check for any IV access. He needs IV access. You give fluid if required, pressors. And then decontamination, for example, if patients has like organophosphorus poisoning, you have to remove the clothes, clean the skin. Also, you can check bedside the blood sugar to just rule out any hypoglycemia, and that can be correct quickly. And then enhanced elimination, usually the most common they give the activated charcoal. If patients came early, usually within 1 to 2 hours, some they recommending whole power irrigations, and then see depend on what kind of poison, if there is any antidote that can be given. So brief history is very important, either from the patient, and this is really most of the time is very difficult as the patient comes with altered mental status or comatose. Family is important to talk with, friends, paramedics, medics. So the most important to know what the name of the drug, what kind of form, like extended release, short acting, long acting, because this really make a difference. For example, if patients came like within 1 hour and that's extended release, then most likely have to act actively because this patient will show toxicity. If came like 5-6 hours and has no sign of toxicity, usually prognosis will be not bad and might not need any interventions. Time of ingestion is, as I mentioned, is important. Review home medication is important too. That might help give you a clue what medication he had. Also, you have to look for over-the-counter medications, herbal medicines, and any history of drug use. So physical exam, central nervous system is very important in toxicology. So you have to look for a level of consciousness. If there is any clonus, rigidity, that can help give you a clue. Fasciculation, tremor, pupils, especially in opioid overdose. But even in opioid overdose, if you have normal pupil size, doesn't exclude the opioid overdose. Sometimes those patients have congest other medications that can affect the pupil size, or some opioid like meperidine can give you normal size pupils. Central nerve, the cardiovascular system. So we have to see, is it patient bradycardic? Is it patient tachycardia? Bradycardia usually, as you know, it goes with more like opioid overdose. If you see tachycardia, then you think about sympathomimetic overdose. Respiratory, if patients have apnea or hypoapnea, respiratory depressions, then you think about opioid overdose, benzo. If you have GI, salivations, important to bowel sound is important to urinary retention, as you see in anticholinergic, skin color, temperature, any sign of drug use, and dry and wet skin can give you some clue. Sometimes the odors, that's another thing. This is just a physical exam, as I mentioned, pupil size, temperature, respiratory rate, skin, tremor, any clonus. So this is give you some clue here. As you see, cholinergic, they can, sorry, opioid can come with low respiratory rate, low blood pressure, pupil is constricted, mental status is depressed. Can give you the cholinergic, can give you this similar presentation to the opioid. And then anticholinergic can give you a similar presentation to sympathomimetic, except for the mental states. And those patients usually comes more altered mental depressed mental status. Sedative hypnotic usually is very important when you see these patients. They come like altered mental status or in coma, but vitally they are stable. So cardiovascular, respiratory system usually it's within normal. Sympathomimetic, as I mentioned, comes with more tachycardia, hypertension, agitation, dilated pupils, diaphoresis. This is just some shows like the some overdose toxicology causing like specific odors, garlic, I season, arsenic, acetone, odor give like an ethanol, isopropyl alcohol, salicylate, rodent eggs, I see then hydrogen sulfide. Initial workup. So initially you can do an EKG. You see if there is any changes. They can give you diagnostic and prognostic information. So QRS, white QRS give you some clue. QTC prolongations. As I mentioned, you check blood sugar, and X-ray can give you some because some drugs can be radio opaque on the X-ray, as you see here. Chlorinated hydrocarbons, calcium salt, heavy metals you can see in on X-ray, iodinated compounds, potassium salt, enteric-coated tablet like an aspirin, salicylate, sodium salt, sustained release preparations. So the lab, usually do urine drug screen, you do CMB, look for any transaminitis, you look for kidney functions, serum osmolarity. It's important to see osmolar gap too. You check for acetaminophen, salicylate if you're a suspicion. ABG, see if there is any hypoxia, hypercapnia, lactic acid level. CO level if you're suspecting CO poisoning, and as I mentioned, osmolar gap is very important, especially if patients came early within a few hours after the drug overdose, and lactic acid and ketones. So general management, as we mentioned, that depend on the poison, depend on the severity of presentations and time from the exposure to the time of presentations. So always start with the supportive care, and this is really the most important step in toxicology. So with airway, as we mentioned, check the airway. Page needs suction, needs intubations. Circulation, have IV access, is patient hypotensive, you resuscitate with the fluid, pressure if needed, and then the decontamination, as we mentioned, like if there is a skin exposure, remove the clothes, clean skin, activated charcoal, as I mentioned, if within 1 to 2 hours. Enhancing elimination technique, you can alkali the urine, for example, in patient with salicylate poisoning or barbituric poisoning. You can do hemodialysis if the drug test can be cleared by hemodialysis, and filtrations too. And as I mentioned, the antidote if it's available. So this is the same, just the supportive care, as I mentioned. If patient has some other presentation with a drug overdose like hypertension, you treat agitation, and most of the time is benzo drug of choice. Ventricular tachycardia, for example, if patient has TCA overdose or carbamazepine, sodium bicarb is recommended. If patients came with a bradycardia, atropine, calcium, if, for example, patients has calcium channel or drug overdose, glucagon, if patients has beta block overdose, also high dose insulin. We'll talk about it later. Agitation, seizure, and hyperthermia, that's all needs to be taken care of. This is the drugs that's amenable to hemodialysis. They called LitMSAP. So lithium, ethylene glycol, thiophyllene, methanol, salicylates, atenolol, valproic acid, and potassium. This is all can be cleared by hemodialysis. This is just the table for the antidote. So you see here acetaminophen overdose, as you know, is in acetylcysteine. That's antidote. If you see calcium channel blocker, calcium gluconate or chloride, if you see cyanide, digoxin immune fab, ethanol, methanol, ethylene glycol, ethanol, or fomepizole, benzoflumazine, flumazenil, and then opioid, as you know, naloxone, anticholinergic, fistustigmin, organophosphate, pralidoxime, and atropine, and TCA, cocaine, salicylate, sodium bicarb. So this is the toxidrome, and usually sympathomimetic can give you some specific clinical presentations, and cholinergic, anticholinergic, sedative, hypnotic, and opiates. So sympathomimetic, what we have amphetamine, methamphetamine, cocaine, bath salts, synthetic marijuana, and cannabinoids. So amphetamine and methamphetamine is very common to see in ICU. So usually comes with a chest pain, comes with arrhythmia, acute coronary syndrome, acute cardiomyopathy, and chronic use can cause chronic cardiomyopathy. They can come with a shortness of breath. They can come with pulmonary edema, pulmonary hemorrhage. Long use can cause also pulmonary hypertension. Can come with a seizure, intracranial bleed, and stroke. Also can affect the kidney, achia, and rhabdo, bowel ischemia, and mainly treatment with patients is just supportive treatment. Bath salts, we have the mifedrone and pyrovalerone, also the what we call the flaca alpha PVP. Usually you cannot detect it in the regular urine drug screen. They come with the sympathomimetic symptoms with very aggressive behavior, and usually they require high dose of benzo. Avoid antipsychotic because it can prolong delirium and psychosis in those patients. Synthetic marijuana and cannabinoids, the same. That comes with sympathomimetic, aggressive behavior plus paranoia. ACA is common, and also they require high dose of benzo. Chronic use can cause memory deficit. Cholinergic, the most common organophosphates, carbamates, and nerve gases. As you know, the symptom we memorize as sludge, so they come with the salivation, lacrimation, urination, diarrhea, GI distress, and vomiting. Treatment is mainly supportive, aggressive, as I mentioned earlier, aggressive skin and ocular irrigation as needed, remove the clothing, activated charcoal if came within the first 1 to 2 hours. Antidote, atropine, glycopyrrolate, and pyridoxine. So the drug of choice in those patients, atropine, because the concern in those patients is the secretion, the respiratory secretion. That's really the cause of mortality in those patients. So if patients, you think he needs intubation, intubate early, and atropine, that's the first choice. Glycopyrrolate, that can be given as alternate to atropine. Pyridoxine, it's more for muscle weakness. It's not considered as the first. The atropine comes first. Pyridoxine has muscle weakness. They added, but the first choice is atropine in those patients. And this is, might see a questions about this. Anticholinergic toxicity, as you know, is most common, and this is medication. Almost most of the medication they have kind of anticholinergic effect. So antihistamine has anticholinergic, antipsychotic, anti-Parkinson medications, antiemetic, and muscle relaxant. Management mainly is supportive. There is antidote, which is the physiostigmine 0.5 to 2 milligram IV, but really is not recommended to be given unless patient came with a pure anticholinergic toxicity with the significant neurological symptom and sign of anticholinergic toxicity, like very agitation or severe delirium. This is anticholinergic toxicity. So altered mental status, they come with tachycardia, constipation, absence of diaphoresis, dry skin, flushed skin, urinary retention is opposite to the cholinergic presentation. Sedative and hypnotics is the most common. We're going to talk about the benzo. So the most common benzo drugs, alprazolam, diazepam, clonazepam, and lorazepam. So the isolated benzo overdose, as I mentioned earlier, usually they come mainly with the CNS symptom like altered mental or coma, but vitally, usually they come vitally stable, no hypotension, no bradycardia or tachycardia. Sometimes they come respiratory depression. Urine drug screen is not sensitive or specific. So if you have clinical suspicion, patient has overdose with the benzo, but the urine test is negative, then you still consider that the benzo overdose. Management mainly supportive. There is an antidote with flumazenil, but really not recommended because high risk of seizure. So this is the contraindications, and mainly really it's just because of the seizure. So patients taking TCA or chronic benzo use, you cannot use it because TCA can decrease the threshold of the seizure. So that's why it's contraindicated. Patient comes with altered mental status with witnessed or suspected seizure. Patient has already seizure disorder, or patient comes with a unknown coma and you give him the coma cocktail, so not recommended to be given. Next, we're going to talk about the opiates, very common drug overdose. The most common medication is oxycodone and hydrocodone. And prolonged effect can seen in sustained release and also with the methadone. So if patients come to you with the opioid overdose, methadone is going to be different in management. Especially with the naloxone. So if patients comes with fentanyl, you can give a naloxone a couple of times and usually do okay. But methadone, usually you have to think about naloxone drip because it's long acting and can stay in the system for a while. So this just keep in mind. Symptom, as I mentioned, altered mental status, bradycardia, respiratory depression, ARDS, and hypotension. As I mentioned, normal pupil examination does not exclude opioid toxicity. Meperidine can come with a drug with opioid overdose, but pupil is normal size, or patients comes with multi-drug overdose can mess with that and cannot give you the typical finding of meiosis in those patients. The best predictor of opioid toxicity is the respiratory rate. It's very important in diagnosis and very important in management. When you give naloxone, you see the respiratory rate does give you a clue if patient's responding to naloxone or not, does he needs to be on the drip or not. So methadone, loperamide can also affecting the heart and can give you mild cardiac symptom to VTAC. So methadone, loperamide, you have to do an EKG stat. Also, on those patients, sometimes they have combination opioid with the acetaminophen, like Percocet, so you have to check for acetaminophen level in those patients. Fentanyl can give you false positive urine test for phencyclidine. Diagnostic workup, just because they comes with the altered mental status, you have to check for blood sugar, acetaminophen level, as I mentioned, EKG to see if there is any EKG changes. And if patient's been down for a while, you check for the CK. Management, again, is very supportive care. Entitled CO2 monitoring using capnography is excellent to see or monitor the patient ventilation. Antidote, as you know, is naloxone. So if you have IV access, you give it IV. If not, then IM, sublingual, subcutaneous, endotracheal, or intranasal. So if you give it and no response after 5 to 10 milligram of naloxone, then you have to rethink for other diagnosis. if you give naloxone and patient respond, and then a few minutes again, go to again hypoapnea, give again, and then you have to think about the drip. And also if patient has methadone, and then I think from the beginning you need to start them on naloxone, on the naloxone drip. So the goal of treatment is adequate ventilation, not normal mental states. So your focus when you treat these patients about mainly about the respiratory rate, not the mentation. So continuous infusion of naloxone can prevent intubation. And so this is questions here. There's a few questions just to at least have some interactions here and keep everyone focused. 39 years old man is brought to the ED. First of all, who's gonna volunteer?
Okay. 39-year-old man.
You can read it if you would like and just answer the questions.
Okay. To the ED by ambulance. He had left home with the friends the previous evening, and his family found him fully responsive to the front porch at 5:30 a.m. in the ED. His glaucoma scale was 6, and he accepted level breathing. Initially, BG reading PO2 96, CO2 101, pH 6.8. By CAP 17, he is intubated. Mechanical ventilation is initiated with normalization of PaCO2 and pH increasing to 7.27. Serum sodium 133, potassium 6.8, chloride 101, CO2 16, BUN 18, creatinine 2.5, glucose 200. Urine toxicology screen is positive for opiate, cocaine, tetrahydrocannabinol, and phencyclidine. UA is negative for ketone. The blood epinephrine and salicylate level are negative. Ethanol is not detected. Serum osmolarity is 314. White blood cells 17.6. Hemoglobin 16.9. Platelet 290. Beta hydroxybutyrate is 0.1. YPC normal. Serum lactic acid is 1.4. He's given 1 liter of 0.9 saline containing thiamine folate multivitamin, followed by additional liter of lactate LR solution, which will the following most appropriate. Next. Charcoal, insulin, flumisol, urine alkalization. Going back to the question. So he get cocaine, opioid, tetrahydrocannabinol, and phencyclidine.
Go to the lab. So his ABG, you have basically combined respiratory and metabolic acidosis. You have an AKI. You have potassium is high.
Potassium is high, yep.
And osmolarity is 314.
Potassium is high, blood sugar is a little
So
bit
high
on the
anemia,
side.
metabolic acidosis.
He has
You need
some
anything
ketones.
else?
No. Urine negative.
Next,
Ethanol is negative. You don't have benzo, right?
it's not
So
sharp.
fomepizole is out, right?
Urine alkalization.
So let's go back and so he's young guy, drug overdose, high anemia, metabolic acidosis, respiratory acidosis, has an AKI.
Could be Italian glycogen, sorry.
And osmolar gap. Did you calculate it? How much? I think it's gonna be 29. Okay.
High, so
Okay. So what gonna do?
dialysis or fomepizole.
Don't know dialysis.
There's no dialysis, so fomepizole.
Okay. Yeah. So the treatment
So
fomepizole.
no insulin, no alkalization.
Yeah. So charcoal hemoperfusion usually come for the drug overdose or medication that's high affinity to protein. Insulin infusion, as you know, goes all with calcium channel or beta blocker overdose. Urine alkalization, usually barbiturates salicylate overdose. Fomepizole, if you have alcohol choice, that's gonna be usually alcohol comes first before the fomepizole. But we don't have that choice here. So here, I'm going to talk about ethanol, methanol, ethylene glycol. It's very important really to know this. So the first pathway is the same, all alcohol dehydrogenase. And then the outcome for ethanol give you acetyl-CoA. And that's why those patients, they don't have acidosis. And then methanol, the end result is formic acid, which is a toxic, and this is acid. That's why the end result give you high anion metabolic acidosis. Ethylene glycol can give you oxalic acid, which is toxic, and glycolic acid, which is toxic too, and those can give you high anion metabolic acidosis. It's very important if patients comes in first few hours, early metabolism is going to be, they're going to come with high osmolar gap. If they come late, and then usually osmolar gap is normal, but the acidosis will have high anion metabolic acidosis. We'll talk about, if you see that the green one there, so folate can help in methanol. Toxicity can facilitate convert formic acid to CO2 and water, and then pyridoxine and thiamine for ethylene glycol overdose. But this is not the main treatment. So this is very important. As you see here, you see the hours comparing to the osmolar gap and acidosis. So if you start the osmolar gap, when they come in first few hours, osmolar gap is going to be high. But if you see the red line there, it's going to be, this is the acidosis, this is the high anion gap metabolic acidosis, and this is the osmolar gap. So when they come first few hours, they're gonna osmolar gap is gonna be high because the first, like the alcohol, ethylene glycol, the high molecules and give you high osmolar gap. But when comes late, then the acidosis is gonna go up, and the same time the osmolar gap is gonna drop. So if they come late, they're gonna have low osmolar gap with high anion metabolic acidosis. So if you see this patient, if it's clinically high suspicion that patient has ethanol or ethylene glycol overdose, even with normal or low osmolar gap, you have to treat. Here we see here that this is if they come with co-ingested of ethanol, so it's gonna delay the osmolar gap drop and gonna delay the acidosis. But this is very important really in the questions on medical practice. Normal osmolar gap or low osmolar gap does not exclude ethanol or methylene glycol overdose.
So if you don't know what to do, they're right.
The problem, we don't have measurement for methanol, ethylene glycol.
And most of the center, I think they don't
send out.
Some centers,
takes time.
some centers they have it in a few minutes.
Yeah, we don't have it.
Yeah.
At University of Kentucky, few minutes.
And
But
the
I don't-
pharmacy will resist you if you will prescribe omeprazole.
Yes.
Because it's an expensive medication.
Yeah, and the alcohol is very hard to dose too, and
The alcohol is no way, and from Brazil, the pharmacy always pushing back.
very expensive as well. So this is just give you what drugs can give you high anion gap, osmolar gap. So ethylene glycol, diethylene glycol can give you high osmolar gap, methanol, and propylene glycol. Others, as you see, CKD, ketoacidosis, lactic acidosis can give you osmolar gap, but usually it's not high. The one give you high osmolar gap with without anion gap metabolic acidosis, and the most important in this, they're gonna be the isopropanol or the isopropyl alcohol. And this is, you can see questions about this. So if you have high osmolar gap, no acidosis, and then you have to think about isopropyl alcohol overdose. Methylone, ethylene glycol, as I mentioned, so that's the most common overdose that you can see, especially ethylene glycol here. So rapid recognition and early treatment is crucial. Methanol metabolite, as I mentioned, is formic acid end result and causing retinal damage, basal ganglia injury. Ethylene glycol can give you the oxalate crystals and can causing acute renal failure. And by the way, the fumibazole, that's the only drug approved FDA for only ethylene glycol and methanol. So treatment, as I mentioned, is alcohol just to inhibit the alcohol metabolism. But as I mentioned, it's very hard to dose and monitor. Fumibazole is very expensive and it's approved for methanol and ethylene glycol. You start with loading dose, 15 milligram per kg, and then followed with 10 milligram per kg every 12 hours. Indication for hemodialysis if patients have very severe metabolic acidosis, osmolar gap more than 25, acute renal failure or visual changes, then you have to do dialysis. Methanol poisoning, as I mentioned, folic acid can help to convert formic acid to CO2 and water, so you can add that, or you can add pyridoxine and thiamine if patient had ethylene glycol poisoning. Isopropyl alcohol as
one question. If a patient comes late without any osmolar gap, it's already, the acid, the alcohol is already metabolized. And usually they function by competitive inhibition. So is it important to give fomepizole, even if you are sure that the patient has like ethylene glycol or methanol?
I think that's what they still
Because
go.
if it is late in the graph you have shown us, they don't have osmolar gap.
It's-
I don't know if fomepizole is indicated in those situations.
They don't
I think if
measure
it's
time.
late, the damage will be already.
Yeah, but that-
Acidosis or if you have concomitant renal.
And then dialysis is gonna-
An indication even for dialysis.
Yeah.
Dialysis,
Yeah.
dialysis as well. I'm not
Yeah,
sure
my
if
thing is-
fomepizole would be, as effective.
Because there is no alcohol.
Yeah.
at that point.
Yeah, it's you have to treat, but you give fomepizole, you do dialysis. I have no really answer on that. But it's the question is, if you have normal or low osmolar gap, you have to treat even if they come
I
late.
think you take it
You give
by
fomepizole, you
patient,
give alcohol, or you do dialysis. But as I mentioned,
individual presentation. To them.
isopropyl alcohol, as I mentioned, the most important in this, just if you see patients comes with this alcohol overdose and you have a high osmolar gap, no acidosis, then your choice will be isopropyl alcohol toxicity, because the end result you produce is acetone. That's why they don't have any acidosis. Who's next? Gonna read these questions.
41-year-old man is treated and released after minor traffic accident caused by a syncopal episode. The following day, he presents to AED after having more syncopal episodes and a grand mal seizure as witnessed. Additional complaints include unrelenting nausea, vomiting, diarrhea for the past week. He has a history of bipolar since his late teens and takes psychotropic medications as well as fluticasone, levothyroxine, omeprazole. He smokes 1.5 pack per day of cigarettes, unfiltered. Cardiac exam normal, neuro normal, except for 3 tremors involving both hands. Serum sodium is 147, potassium 3.7, biochar 19, chloride 20, 136, 13.1, glucose 97, WBC 16.2, osmolality high 318, TSH 5.5. Which of the following is most appropriate treatment? Okay. Can you go back again?
Because
We had seizures.
This looks like more secretions, more cholinergic system was activated.
So the history has like
Psychotropic medication.
that's very important. And then has a tremor.
sodium on left side.
Sodium is slightly up.
So can we go to the options?
He has no data.
If you don't know the lies, it's like wide complex. It's like wide complex tachycardia. If you don't know to do amiodarone. It's
not
lithium
happening.
toxicity.
But let's take it one by
Where do
one.
you think
So-
toxicity coming from? What?
Psychotropic medications and increase cholinergic.
So he has a bipolar disorder. So what do you treat bipolar?
Hemodialysis, lithium.
Lithium. Okay.
Yeah,
So what do you
Yeah,
think?
lithium toxicity.
So hemodialysis, you think?
hemodialysis.
Okay.
Probably very thin. It's reacting 0.9.
So lithium is more commonly as sustained release. So that's very important. Really, when you come and call you from the same area, they say this patient has lithium overdose, but the level is low. Then you have to monitor and have to do it every 2 hours because that's gonna take time to go up slowly in the system. So if they call you, they say there's just as 2, that might go up to 4 or 5. So you have to closely monitoring lithium level in the next couple of hours. So as the toxicity dependent, what's his kidney function, the dose, volume status, if he dehydrates is going to be high risk, and chronicity. Presentation can come with acute, chronic, acute on chronic. Acute toxicity, mainly they come with the GI symptom because they don't have time to go to the lithium to penetrate the neurons, and usually that's why they come, the neurological symptom, it's kind of delayed. If it's chronic, usually early they come with early and predominant symptom of neurological symptom, ataxia, confusion, tremor, and fasciculation, seizure. Acute and chronic, they come with a combined acute and chronic symptom. kidney, can cause nephrogenic diabetes insipidus. And this is really important in the question. If you have this and you have low anion gap, think about lithium. Cardiac, they can cause arrhythmia, EKG changes, flattened T wave, prolonged QTC. As I mentioned, serum, a serial lithium level Q2 hours is recommended. Treatment, adequate volume state, make sure they are on IV fluid. Hemodialysis if had very severe symptoms, serum concentration more than 4 with renal impairment, seizure, and acute renal failure. And we have one patient with lithium overdose a few days ago in St. Mary.
Where charcoal doesn't help much.
Mhm.
Doesn't help salt.
Yes. Yeah, that's not.
So if you suspect lithium and you have seizure already, you have to dilate.
Call nephrology. That's one they call. Dr. Beam refused to admit him to the
One
ICU.
session of dialysis, you get the level
Yeah.
go down very quickly. It's just very easy there.
If you
Yes.
they call it back.
No, the medicine they admit him. They call nephrology. It was, I don't know if they did any vascath on him or not. Okay, I was gonna read this question.
28-year-old man is admitted to the ICU after being found unconscious in his smoke fetal department where his
Fire
house
department.
was on fire. I'm confused.
Dragon.
He was brought to the hospital on 100% face mask and awoke in her house. He's awake but mildly confused and does not know what happened. Oxygen saturation 100% and 100% non-repeater mask. Vital include respiratory rate of 30 per minute, heart rate 126, blood pressure 165/92. Skin has cherry red color. Lab include following ABG showing 7.08, BCO2 21, VO2 is 228 with CO oximetry demonstrating 0.3% methemoglobin and 5.2% carboxyhemoglobin. Central venous saturation 100% with mixed venous gas, tension 199, which for long is next significant treatment of this patient. I think he has cyanide poisoning, right?
What the guy do?
What? There's no evidence.
What's your treatment?
So, administered vitamin B12, that's, I think, out intubate for pre-version bronchoscopy.
Shaheen is thinking.
Intervention. So not sodium bicarb,
BB,
not high, not vitamin B12, but infused methylene blue, right?
Everyone is
No.
agree?
No.
Intubate.
First one.
Hydroxy.
Yes, yes, that's drug of choice.
I don't know that.
Intubate, then give the.
Zalux.
He's very technical. Like. No, to give him break because of to give the diaphragm break.
So cyanide poison exposure to metal extraction, nitrobroside, smoke, and fire exposure. Usually it's uncommon, but high clinical suspicion needed for diagnosis. Presentation similar to CO poisoning, and usually they come like the same, like with CO poisoning and cyanide at the same time. So it comes with hypotension, seizure, high lactic acid, cherry red color because the high affinity of oxygen, even when you do a venous gas, it looks like an arterial gas. That's why when you see the gradient between the venous and arterial is very close. Rhabdo, multi-organ failure, severe anion metabolic acidosis and elevated lactic level, cherry red color, right red venous on fundoscopy is a classic early finding of cyanide toxicity. Management is supportive and antidote cyanocobalamin drug of choice if you clinically suspect. Sodium nitrate and thiosulfate is alternate. So the guideline recommend empiric administration of cyanocobalamin in any victim of a closed space fire with the Glasgow scale less than 14, respiratory distress, hemodynamic instability, or disproportionate or persistent lactic acidosis.
Not the first.
Shaheen.
42-year-old woman with type 2 diabetes, depression, obesity was brought into the ED by her husband for confusion and ultimate status. She reported that she has been more depressed lately and stated that he is concerned that she may have overdosed. Found nearly empty pill bottle for glipizide, 20 milligram, in the bathroom this evening when he returned from work. He said that she had a normal mental status this morning and doesn't know the name or the other medication she's prescribed. We were called to evaluate her in the ED exam. She's minimally responsive. That's it. Vital signs, temperature normal, blood pressure normotensive, pulse 72, respiratory rate 14. Rest of the exam is unremarkable. Point of care glucose is 40, and she is given 50 ml of dextrose IP push. Her follow-up point of care glucose 60. Shortly after that, thereafter, her repeat glucose fell to 48. That's I think that's beta blocker toxicity. Second dose of 50 ml dextrose in water IV was pushed, repeated the glucose 65. Her serum chemistry showed sodium 139, potassium 3.2, fluoride 105, bicarb 24, BUN 18, creatine 1.4, glucose 60. In addition to recommending that she will be admitted to ICU, what is the most appropriate next step?
So the question is we know the overdose, that we need a treatment now. So what do you think?
I think glucagon, that's or octreotide.
Which one?
No, glucagon, right? Glipizide.
I think
I will go with-
And then standard for the supplementary appointment.
Glucagon, right?
So
I think the trick here is they give her D50 twice and their blood sugar is still low. Maybe glucagon will not be
glucagon.
helpful.
yeah, so the choice is octreotide. Why? Because she been a couple of times, she got dextrose and she continue. And if you
Yeah.
continue to do that, it's gonna causing like a cycle. You give, you're gonna increasing the insulin release, go more hypoglycemia. So this is not an option. Other option, if you're gonna give glucagon, is what's glucagon do? Glucagon gonna do gluconeogenesis, and that's gonna
Yes.
go up glucose, gonna go more
Insulin.
with insulin release. So what you do, you have to suppress the insulin release. That's why we do octreotide in those patients.
Well, I thought it was an insulin overdose.
Insulin overdose.
Yeah. You'll go-
Insulin you
I-
go, I think, with the glucose.
Yeah, with the glucose.
I think the sulfonylurea is the problem. Sulfonylurea is insulin producer and it takes long time. It's prolonged.
for sulfonylurea, octreotide is the best. For sulfonylurea.
Yeah, because you're suppressing the insulin release. That's all. Oral hypoglycemic overdose, so risk factor, old age, taking multiple medications, long-acting medications, impaired drug clearance, renal hepatic dysfunction. Manifestation, mostly they come with altered mental states, diaphoresis, management, IV dextrose first, but if not, then octreotide, that's inhibit insulin release. And usually give 50 IV or sub-Q, followed with 3 additional doses.
That's a drip.
Hmm?
That's a drip.
No. Renal replacement therapy would be indicated for severe metformin-induced metabolic acidosis and lactic acidosis. So just bradycardia and toxicology, most common with the beta blocker, calcium channel blocker overdose, clonidine, barbiturates, digoxin, organophosphorus, and sedative hypnotics. So question, Raru.
56-year-old man with history of depression, hypertension, and also admitted to medical ICU. After unintentional overdose of amyloid, We took 25 10 milligram tablets in the emergency department, 2 liters of crystalline and 3 grams of calcium gluconate was given. Upon arrival to the ICU's vital signs, showed temperature 37.1, blood pressure 75/40. Heart rate 110, respiratory rate 70, and 98% saturation. On exam, is a wet alert and oriented kind of lungs are clear, cardiac exam is notable. The remainder of his physical exam is normal, serum chemistry, sodium 140, potassium is 0.9, chloride 101, bicarbonate, opium 90, creatinine 0.9, glucose 225. In addition to administering additional 3 grams of calcium gluconate, followed by high dose continuous infusion 1 liter of crystalline, which of the following is the best next stage management.
Glucagon. That's
Administer high dose
Insulin.
high dose insulin.
He's on the high dose insulin. He said, yeah?
No,
Would you
it's
go
not.
back?
No,
High dose continuous infusion.
no, that's a calcium gluconate.
Calcium gluconate.
So I think it's the insulin.
Why not a glucagon?
Because it's amlodipine.
Glucagon. Yeah,
It's calcium channel blocker.
Yeah, so
Calcium channel blocker toxicity.
beta blocker or beta blocker. glucagon.
both of them.
calcium
Also
channel
can-
blocker.
I think the
we do
next best thing
glucose
is
insulin.
insulin.
Yeah.
I would say insulin.
So,
Yeah, so the answer is high dose insulin. You know what's the dose?
it's very
one
high,
per
it's gonna
kg.
be.
Yes.
1 unit per kg. That's the bolus, and then 1 unit per kg per hour. Yeah. So
Why not glucagon?
we'll talk.
No.
So the beta blocker, calcium channel blocker overdose presentation is very similar: bradycardia, hypotension, cardiogenic shock. Some they say the calcium channel blocker can come with hyperglycemia and beta blocker with hypoglycemia, but I don't know really that's very significant to differentiate. Diagnosis, as I mentioned, just this presentation. So management. You have to give fluid just because of hypotension. You give atropine for the bradycardia, and then with calcium with the beta blocker overdose, you give IV glucagon. That's your drug of choice. That's the first. Give 1 to 5 milligram IV push, and then you repeat up to max of 15 milligram. If need, you can do vasopressin, levo, and then high dose insulin and glucose infusion comes after. Before you do that, make sure patient is not hypokalemic. Make sure patient his blood sugar at least more than 200, and you have to, if low, then you have to start D5 with it. So you usually give 1 unit per kg bolus, and then 1 unit per kg per hour, and you can go up to 10 unit per kg per hour. You have to have protocol, yes, and we don't have it here. So Yep.
10 units.
10 units. So see if
Like 70 kg person.
it's again 700.
This is high. So we had one patient at Kabul, I think last year, with the same situation. So when we read about it also, they also recommend doing endoscopy early because the medication can be get like a stone in the stomach. And we did that, and they like remove it like as a stone.
It was very difficult to manage.
Yeah, and then
She was in 4%.
and then the lipid therapy.
In high center, they put
They scope her and they get like a stone, big
Because
stone of
one
medication.
initially-
Yep. So high dose insulin therapy has been shown to increase ionizing calcium and ionotropy in the setting of calcium channel blocker toxicity. As I mentioned, hypokalemia should be corrected before you start. And if less than 200 blood sugar, you have to start IV dextrose. Hemodynamic response may take 30 to 60 minutes after starting the high dose insulin therapy. But before that, in calcium channel blocker, so in beta blocker overdose, your first thing is glucagon. In calcium channel blocker, you start with IV calcium. Better to give IV calcium chloride because it's very concentrated, but you have to have a central line for that. If not, then you do IV calcium gluconate, but you require more doses for that. Usually give, or you can start infusion from the beginning, calcium infusion. High dose insulin, as I mentioned, and then IV lipid emulsion infusion, pacemaker, and sometimes patient has refractory shock, they send them for ECMO. So 2017 expert consensus statement was published recommending stepwise approach in management calcium channel blocker poison in adults. So this is a really nice diagram there if you see. So you do the decontamination, and then patient has symptom, you have to admit to ICU for close monitoring. And if patient had the symptom hypotension, bradycardia, you start with IV fluid. This is all for the calcium channel blocker overdose. So you do a calcium IV, as I mentioned, increasing contractility and blood pressure, and then pressure if needed, levo and epi. If you can use a high dose insulin. You start to and this is if all these measures is still patient's hypotension, then you can do what we call incremental doses of insulin. Then when you go to the 10 unit per kg per hour. If this failed, you can try the lipid emulsion therapy. If this failed, then you have to refer for ECMO. If just bradycardia, then you have to do a pacemaker if needed, lipid therapy. And if this fails, again, you have to send him for ECMO.
Well, they are not the allies, right?
What's that? No.
The patient we had in the ICU, I remember the patient takes both medications, calcium channel. It was difficult to.
Good combination.
Yeah,
which one is
insulin.
So yeah, we did different things, but we
Here
had to
in-
look up. Yeah, in the ICU, like some months ago.
Because he was hypotensive?
He was hypotensive. He ended up on levo for some days, or like.
Okay,
Okay.
because usually it takes time to be cleared from the
Yeah,
system.
but honestly, we don't know whether it is calcium channel or.
Oh, beta
Look
block.
at on 1 hour insulin 1 hour.
Yeah.
Combination. But I didn't do insulin drip, did you?
No, we did not.
It's significant.
Patient needed drip and the scopper.
What?
The scopper. We like really found like a big storm of this medication together.
So this patient, if not responded, you had to send him somewhere for insulin. I mean, this is really.
Dr. Al-Jazmi, you have.
I don't think he's gonna wait until